Hello. Just make sure I get a confirmation that we're live and that it can be seen here. Just 1 second. Okay, let's get started. My name is Dr. Joseph Smith, and I practice in Fairfax, California, which is just north of the Golden Gate Bridge in Northern California. And the name of my practice is called Atlas Health. And we see people from all over the US and some international that are needing a healthcare solution to their problems. So what we do is we tend to see folks that are plateaued in their healthcare, or they have tried a few things and just are still looking for answers out there. If you'd like to get a hold of us here, our number is 415-459-4411, and our email is contact@atlas-health.net. And we've really enjoyed the response to folks watching our Facebook Live events. Jessica Flanagan and I will be doing another event next week. We don't have it the topic yet, so if you have any topics you're interested in, let us know. But we'll be doing that, I believe, next Wednesday or Thursday, so we'll be putting an announcement out about that. So we've had a lot of conversations over the years, and I just want to say that one of the biggest things that we hear here, that I hear when I'm working with clients, is that they are so happy that somebody understands what's going on with them. And I talk to a lot of folks that aren't patients, that aren't seeking out help with me, and they start talking to me about what's going on with them. And I really feel like if people just knew what was possible and what was out there for them, they might think differently about what's going on with their health and their lives. You know, a lot of folks are just out there dealing with something. They're resigned to the fact that they're stuck with it because some, high-level doctor told them that there's nothing that can be done, or maybe they've been told that they're just getting older. I can't tell you how many people that have presented to me that have really, really significant out-of-range stuff on their labs and in their history, and they're just basically told it's normal that they're getting older, that they're a parent of 3 kids and maybe a single parent, and they just need to get used to the fact that they're just not going to feel well. Or that, here, maybe take this drug to help with their depression and they'll feel better, or take this pain medicine. And that's cool that they want to help them with the drugs. But when the drug doesn't work, there needs to be some thought that goes into what's going on with their case. In the alternative model, they might say, here's this adjustment, or here's my acupuncture treatment or my cranial sacral therapy. And if it works for your symptom, then it worked, and so cool. We'll see you next time. And if it didn't work, then all right, let's do it again. And some doctors in that field will say that medicine's bad, and so there isn't really a lot of collaboration between practitioners. And then there's this emerging model, which I feel very fortunate to have had some great teachers to help me become part of, and we feel like we're riding the front of this wave. And it's really not about what we can do. It's really more about what your needs are, and identifying a person's physiology and figuring out where the problem is and how to jump in to create basically a healthcare model that is specific for that person at that time, and then be able to adapt it when things change. And most of the cases that I see now are very complex cases. They've seen a number of doctors and had moderate or no success. And we identify like 10 variables. And some of the doctors they've seen have done awesome work. There's some great doctors out there, and they're doing great work, and they remediate 3 of the variables, but they weren't aware of the other number. And so ultimately they were regarded as a failure because the symptoms didn't get better. But I would say that those folks have succeeded because they've remediated 3 of the variables. So I think part of this whole thing with complex cases is setting expectation and understanding what's going on with the physiology. The thrust of this class today is part 2 of understanding why a person's dietary change, like autoimmune paleo or SIBO diet, didn't help them with their acid reflux or their SIBO symptoms or their digestive disturbance, constipation, diarrhea, etc. Most of the folks that contact us have already made the dietary change. They're very versed in food elimination plans. They're very versed in supplements. And most of the supplements they've seen have focused on their gut. Okay, so today the goal is to review a little bit of what we covered last time, and then I want to get into some of the neurochemistry applications of what we learned last time. So if you hadn't had a chance to see Module 1, it's embedded in the Atlas Health page here somewhere. In fact, I think if you go right to videos, it's there. So, and then Jessica Flanagan and I have done a couple of videos on, one was on SIBO, and one was just on something called oral tolerance. And so those are some great concepts that would dovetail nicely with what we're going to talk about today. So the goal today is to review a little bit what we covered last time. And so the idea is that folks that have chronic digestive issues that are not resolving to all of the probiotics out there, to all the digestive enzymes, they've had several stool tests done, they've had biopsies done, they've had endoscopies done, they've had upper GIs done, lower GIs done, they've done every test under the sun, and some of them become positive and they remediate what's positive on those tests, those stool tests, etc., and they're still getting symptoms. Then that means, all that means is that, great, those variables are off the table, and now we have to dig and figure out what else is there. The concept that we talked about last time in relation to this was something as simple as the person is afraid. They have a overactive amygdala, which is in the subcortical area, in the temporal lobe of the brain, and that amygdala is basically telling them it's overactive. So it's telling their parabrachial nucleus, if it's overactive, it might tell them to hold their breath and breathe differently, okay? If it's overactive, it may project to the locus coeruleus, and it might tell them to release epinephrine and norepinephrine and trigger a neurotransmitter stress response in the body, which will elevate heart rate and cause sweating, okay? It may project to the periductal gray, and that's your fight, flight, or freeze. That's the freeze response. So that's the rabbit that's just stuck and won't move. That's the person who doesn't want to go out, not because they're tired, but because they have unchecked anxiety socially, because their amygdala is making them feel like they're not safe. And so the periductal gray can help them stay put. Also, the orbital frontal cortex will help them stay put. That is our impulse control center. So the amygdala can say, hey, orbital frontal cortex, make sure we don't go anywhere. It can actually increase frequency of firing of the orbital frontal cortex. The amygdala can fire to the hypothalamus, and it can say, all right, we need to increase our long-term hormonal stress response. So we start releasing cortisol. And we touched on that a little bit, how cortisol can cause changes in our body composition over time, where we store more fat around the middle, and we get short-term memory loss. That's due to damage to the hippocampus, which is another part of the brain that regulates the amygdala, so it becomes a vicious cycle. This contributes to coronary artery disease. It can contribute to immune system dysregulation that leads to autoimmunity and cancer and chronic infection. It also contributes to lack of blood flow to the stomach and the intestines, and that's where we start to get some of the digestive disturbance. When there's no blood in the stomach and the intestines, there's going to be no digestive enzymes. There's going to be decreased motility due to lack of firing, or increased motility due to increased amount of toxins in the bowel because of improper breakdown, and becomes a big issue. Now, we didn't touch on this too much last time, but the idea is that high cortisol also creates something in the adrenal glands called a pregnenolone steal, where instead of making sex hormones in abundance, we just make a bunch of cortisol. And what that does is it can create changes to the female cycle, so it can make it shorter or longer based upon what else is going on. And it can create this situation where a woman can start to become estrogen dominant. And so we know estrogen dominance is a huge deal. We know estrogen has a huge impact on, for example, serotonin, which we're going to talk quite a bit about today. We know estrogen has a huge impact on mood and behavior, and we know that there are estrogen receptors in the body, and when they're overstimulated, oncogenes can activate, and that can be a mechanism of estrogen-positive cancers, which is rampant in our society related to breast and, for example, prostate cancer. So we get this estrogen overload, and then we have high cortisol, which shuts down our dorsolateral region of our brain, which then puts us more in fight or flight, which then reduces our rest and relax system, which primes the amygdala even a little bit more. And then it also decreases our vagal activation through the intestines. So now we get less blood flow and we get less neurological stimulus. And by the way, that affects our liver detoxification as well. So we have high estrogen, and then we have inability to detoxify it properly. So you can see how these vicious cycles can take hold, and how a practitioner can jump in and maybe do a liver detox, or maybe do a bowel cleanse, or maybe do some stuff to work with the adrenals. And if they're a simple case and it's early and it's not complex and there's not all these other variables, it works really, really well. And those are the people that do a liver cleanse, or they do an adrenal adaptogen, or they do a bowel cleanse, and rainbows and unicorns come out and everybody's really happy, and they're high-fiving their practitioner, and then they're on their way. It's a really cool thing. But for those that are having a problem related to digestive disturbance, what we're going to talk about today is building upon this idea about the amygdala, and how an overactive amygdala can create a situation where the body shifts neurologically from rest and relax, digest and absorb, to fight or flight. I got to get the heck out of here. I'm not comfortable. I need to figure this out. And so it can create fear and anxiety, which is not conducive to healing. We talked about some aspects of child development in which a child can maladaptively attach to their primary caregiver, their mom, their dad, or whoever's taking care of them. And if they don't have a secure attachment, if they have any deviation from that, they may be likely to develop a hypervigilance, either to stay away from people or to try to soothe them and be over-concerned and smother them. And that can lead to an overactive of the amygdala. And that area gets like push-ups. Every time they have a relationship or interaction with somebody, that is reinforced. And that creates a dominance of an aspect of the brain that says, I'm not okay being around people. I'm going to keep them at a distance, or I'm going to try to keep them really close and make sure they don't leave me. And that can affect the aspect of frequency firing of the amygdala. And that will result in that increased fear response, which goes to the hypothalamus and these other areas of the brain and triggers a cascade of events that says, my guts aren't going to heal. In fact, if I take a bunch of supplements that are designed to go through my digestive system and I'm stuck in a fear response, what's the likelihood those are going to work very well? Okay, that's why some drugs and that's why some supplements are cream form or IV form for medications, right? Because they just get there a lot faster and they do their job better because it's primarily not a gut issue when the gut can't actually do its job, okay? So today what we're going to do is we're going to delve into some of the neurochemistry aspects of this whole thing. And so I want to talk about serotonin for the next 15 minutes or so. And so actually it's a really short conversation. All you need is to say this. What are some symptoms of serotonin issue? Okay, we talked about the amygdala, and we talked about how a neurotransmitter coming from the dorsal rapid nucleus that's serotonergic can actually calm the amygdala down, and that's why some medications like SSRIs work so well. Well, what does serotonin issues look like? And we have this form in our office. It's called a Brain Health Nutrition Assessment Form, and we ask questions for folks looking at different neurotransmitter systems. And so I'm just going to list some of the symptoms. And loss of pleasure in hobbies and interests, feeling overwhelmed with ideas to manage, feelings of inner rage or unprovoked anger, feelings of paranoia, feelings of sadness for no reason, a loss of enjoyment in life, a loss of artistic appreciation, feelings of sadness in overcast weather, a loss of enthusiasm for favorite activities, a loss of enjoyment in favorite foods, a loss of enjoyment in friendships and relationships, inability to fall into deep, restful sleep. That's the person that wakes up at like 4 in the morning. You know, like, did you ever have like a parent or a relative that, you know, they're just always up? And so what they did is they just went to work at like 4 a.m. or they just went to work out. Well, I'm up, I might as well work out. That could be a low serotonin issue. Feelings of susceptibility to pain. So like one of the things that women that are estrogen dominant, what happens is it affects their serotonin receptors. And when their estrogen levels peak or when they trough out, they actually can experience a rapid change in their pain. And so they may actually experience more physical pain at that time. And they may experience more emotional pain at that time. And boy, that can really affect your mood and your cortisol levels, which can drive the amygdala. And you can see how that can create some anxiety pretty quickly, right? Okay, so we start to see this. People with digestive disturbance, that when we start looking a little bit past the intestines, we say, wow, these folks also have some symptoms that are suggesting they have some serotonin issues. How do we actually modulate serotonin, and how do we take a look at that system? So this is the part that in the standard of care is really easy. We just tell people they're getting older. We just tell people that it's normal because they have children and they're going to have low serotonin from that. We tell people that, you know, it's genetic. We tell people that you have a deficiency in 5-HTP and give them tryptophan, or then give them an amino acid precursor. Or we tell them, here, take this medication, take this SSRI, take Prozac, and everything will be fine. That's the best we can do for you. We'll see you later. That's really easy. That's basically what's out there. But here's the deal about serotonin. I'm not just going to tell you to go take 5-HTP. In fact, people that take tryptophan can do much, 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 much worse if their brain is already inflamed. And maybe you've heard of somebody who had some anxiety and sleep issues, and they were told that they needed some serotonin support, so they went and took tryptophan, and they got much, much worse. Okay, that person has an issue possibly in what's called their brain, called a glial cell ramification, where the glial cells, which are designed to help neurodevelopment and neurogrowth, actually get changed over to neurodegeneration. Okay? And when that neurodegeneration takes place, they think that nutrition was their enemy, and they swear off it for the rest of their lives. And that's kind of a big deal. Okay? Can anybody just make a comment on the live comment section? I want to make sure that we're broadcasting. Can everybody see me there? I just wanted to stop and make sure. Okay. So people aren't seeing me, huh? Okay, cool. All right, cool. We're good to go. Awesome. Thank you. Last time we had this situation where I did the whole broadcast and nobody could see me. So just making sure. Thank you. Okay. So we're gonna go way beyond, hey, let's take some tryptophan. We're gonna go way beyond, hey, I'm gonna refer you to your MD for SSRI. And by the way, a lot of people with chronic digestive disturbance have figured that their brain is related to it, and they've already tried that. Okay. So there's a book out there that I want to just mention, written by a colleague of mine. His name is Robert Malello, and it's called Disconnected Kids. If you're interested in the brain and the brain development, you have to read that book. If you have children, or you know people with children that are showing some asymmetries, or how do I say that? Some behavioral or some academic things that are maybe not what you're looking for out of your child, take a look at this book. It's really cool, and it gets into some of the things that we talked about as it relates to the brain and activation of the brain, and how we can actually use push-ups to part of the brain to help solve some of the issues we're seeing here. Okay? All right. So here's the deal about serotonin. We know that serotonin comes from the dorsal raphe vagus nucleus, and it can have an impact where it decreases the amygdala. That's kind of a really important thing. We also know GABA does that too. We're going to do a whole other Facebook Live on GABA. But in the next 10 minutes, I want to try to break down what we're going to do here with serotonin. Now, before we even get into serotonin, we have to understand that the brain runs on oxygen, it runs on glucose, and it runs on activation. Okay? So here's the deal. If a person doesn't have oxygen, if a person doesn't have stable blood sugar, and if a person does not exercise or move properly, there's no chance for serotonin. There's none. It's really going to be an inefficient system. Serotonin comes from a part of the brain called the dorsi raphe vagus nucleus in the brainstem. It's a midline nucleus. Now, if that area doesn't get stimulated, we have no serotonin. That's the person that goes and exercises and their anxiety gets better. Okay, they activate their dorsal-raphe magnus nucleus and they activate the serotonergic system. It projects to the amygdala, they feel better. It projects to the dorsolateral cortex and they feel like they can concentrate better and they're just in a better mood. Okay, but the brain really requires a ton of oxygen. So what do people with chronic digestive disturbance have? They have anemia. It's everywhere. They have iron deficient anemia. They have macrocytic anemia. They have pernicious anemia. They have so many different types of anemias due to malabsorption. And then if you take a genetic issue where you do not convert certain B vitamins and you put that on top of malabsorption, welcome to a terrible working, brain fogged, tired brain. That's what happens, okay? So here's what happens. There's a cell body in the dorsal-raphe magnus nucleus that receives tryptophan. Now, where does tryptophan come from? It's a protein that comes from the diet. Do people with malabsorption have issues absorbing proteins? Can you see what a vicious cycle this can be? Okay, for tryptophan to even get into the brain, it has to cross this thing called the blood-brain barrier. Blood-brain barrier, another dead marker, okay? The blood-brain barrier. And so we eat protein, and it breaks down in the stomach, and we make branched-chain amino acids. Those cause an insulin surge. That insulin surge causes tryptophan to cross the blood-brain barrier and go into the cell body. Now, that's why people binge on carbs so they can beef up their insulin and have comfort food. That's one of the reasons why people love carbs, because in the short term it raises serotonin levels. Isn't that interesting? So might we want to know something about oxygen to the brain, and might we want to know something about blood sugar for that individual before we just dive in and start giving them serotonin support like 5-HTP? Might we want to know something about their neurological predisposition to inflammation before we just dive in and start giving them tryptophan? Can you see why it doesn't make sense for a practitioner to just start saying, yeah, go to the supermarket and try this, try that? Because first of all, we don't know anything about what's going on with your brain if you just tell us you're tired and have digestive disturbance. And second of all, we don't know what else is in that supplement. Okay, supplement industry is very unregulated. So there's just a lot of things going on out there. And so as a patient, you just need somebody that's going to figure out the physiology. Okay, anyway, so we have this tryptophan. Now the tryptophan gets converted and it gets made into serotonin through a process, okay? So the tryptophan, through this process, gets changed into 5-hydroxytryptophan, which requires iron. Hey, by the way, vegetarians, I love the fact that you are cognizant about the animals that other people are eating, that you're choosing not to eat. And I love the fact that we need to pay attention to animal cruelty. I don't love the fact that it's very difficult to extract iron from plants unless you're from India. And I don't love the fact that a lot of people that are vegetarian come to see me and are depressed and are having a hard time with their digestion, and their ferritin and their iron levels are ridiculously low, and they have no ability to make serotonin, and they're anxious as all get out, and that's why they're not getting better. But then the conversation is, I can't actually eat meat. And that becomes very, very, very tricky, okay? Supplementation can help for a while, but ultimately we need to restore function. Okay, now by the way, this takes an enzyme to convert that, which is another protein. Okay, 5-HTP gets converted to serotonin. Okay, and that requires a bunch of cofactors. It requires methylated B12, methylated folic acid, it requires magnesium and zinc, B6, a phosphorylated B6. So if you take vitamins that are not methylated or phosphorylated already, that's probably a bad idea. So when you're looking for B6, look for P5P, and when you're looking for B12, look for methyl SP. Methylated B12. Methyl SP is the supplement that we use for that. Okay, but some people have a genetic issue where they actually don't methylate very well, and that's a big deal, okay? And they have a genetic issue where they don't methylate very well, and then they also don't do another type of methylation very well, and they do worse on B vitamins. So there's some cool testing out there from Genomind And there's some cool testing out there from 23andMe that can help sort that out for you. So anybody that takes B vitamins and gets more anxiety, we have to decide, did they increase the frequency firing of their brain, or did they just take the wrong thing for their genetics? Okay? Now serotonin then gets transported down this axon to the terminal, and then it gets released into the terminal. And then it fires another neuron down here. But can you see how if there's another neuron up here, and it's not firing into this one, how it's not going to take that tryptophan and do anything with it? It's going to have a decreased frequency of firing? That's a really big deal. Okay, so we know that if you don't activate the brain, this isn't going to happen. The metabolic activity won't take place. So you can take all the great vitamins, and you can actually eat protein, digest and absorb it very well, but then if you do not activate your brain, you do not move, you do not use your mind, you do not get stimulated, then nothing's going to happen. Now, people that have attachment issues have asymmetry in the way in which their brainstem develops. People that have ADHD and that are on the spectrum have asymmetries often in the way in which their brainstem is developed. And so they do not have the capacity to activate. They don't have the capacity. That's like telling a child to, like an infant, to get in a car and drive a car. They don't have the capacity to do all that stuff. Some people do not have the capacity to make this stuff, to run that entire pathway. And that's where seeing a functional neurologist, this is written by a doctor that is really well-versed in functional neurology, can be the most overlooked thing in that chronic complex case. Okay? Now, if a person wants to activate the brain, but then they don't have oxygen, their blood sugar is too high or too low, or they binge on carbs too much and the insulin goes up and then comes down, or they have diabetes, can you see how they're going to have some problems with serotonin even if the brain is activated? Okay? So that's kind of an interesting story, isn't it? Now, once this serotonin is released, there's like 7 or more receptors for serotonin down here. Some people have just genetic issues down here, and they actually might need some medication. Okay? Some people have a genetic issue where they don't clear serotonin, so it overstimulates this neuron, and then it starts ignoring it. That's a big deal. Okay? And so there's ways to sort out by looking at their diet, are they getting enough protein? By looking at their insulin, are they transporting across the blood-brain barrier? By looking at their activation, are they actually having the potential or the capacity to make this happen? By looking at their conversion issue, by looking at forms, we can start to say, wow, they do have an iron issue. They do have a magnesium issue. They do have a B12 methylation or folic acid methylation issue. We need to address that. And then by looking at this down here, do they have a COMT issue or a genetic issue that's causing this to be messed up? Okay. Do they have deficiencies in molybdenum that are affecting the receptor sites? And we can say that there's actually a way to go through systematically each and every step of this entire process. And there's a way with history and good forms, okay, to actually go through and decide, do they have an oxygen issue? Do they have a glucose issue? Do they have an activation issue? Do they have chronic digestive disturbance? And do they have some sort of anxiety or fear-based thing that nobody's connected? And we go through this process of identifying the key symptom they want resolved, digestive disturbance, determining what they've done so far to look into it, deciding that they've done everything they can do for that area, and then we start looking outward based on that. And sometimes we find a neurological component that's related to development. Sometimes we find an overactivation of the amygdala that's related to chemistry and the inability of serotonin and dopamine to come in and modulate that. Okay, so today was a little bit of a review on serotonin. And the reality is there are herbs, okay, there are herbs that can go in there and affect this receptor site. There are supplements you can take that increase iron and that can help with methylated B vitamins. There are supplements that you can take that stop inflammation so the tryptophan doesn't convert to a pro-inflammatory amino acid instead. Okay, there are activities that we can do specific to the brainstem that activate the dorsal raphe magnus nucleus that will contribute to the capacity to develop frequency firing in the system. And that's the story that I think is the most exciting story, because what the standard of care is just to throw supplements or drugs or some excuse like genetic or just get used to it at somebody. But the reality is we can look at physiology and we can say what is actually happening in the system and how do we systematically identify the variables and address each and every one, if possible. Some people do have ablative lesions where the area is just gone, it's not coming back, and we need to work with the ability to compensate, but that's also out there as well. Okay, so summarizing, we have folks out there that are walking around with chronic SIBO or chronic acid reflux or digestive disturbance, irritable bowel syndrome, and they're not responding to therapies focused at that area because their practitioners are very loculated and they're focused only on the bowel. That same person may have some symptoms of anxiety, insomnia, depression, lack of enjoyment in life, chronic stress that's reducing serotonin, an attachment issue in their history, or something like a concussion. Or maybe when they were a kid, they were diagnosed with ADHD. Or maybe when they were a kid, they were diagnosed with oppositional defiant disorder. Things like that, okay? And we start to link those two things, and we start to say, on a spectrum, which one of these variables that we talked about today related to the amygdala overactivation and related to serotonin are present, and which one of these are modifiable? How do we measure them, and how do we intervene? And my experience has been, and that is my colleagues as well, that if we do a good job identifying the circuit, whether it's developmentally injured or degenerated, if we do a good job looking at lifestyle, seeing if the capacity activate is there, is the activation actually taking place with proper exercise, and we look at diet to make sure they're getting enough protein, and we do questionnaires in history to see are they getting enough digestion of that protein and absorption, and then we look at things like blood sugar to make sure that they have enough insulin or not too much insulin to get glucose, easy for me to say, to get tryptophan and glucose across the blood-brain barrier. And then do the cells have enough energy to actually take that tryptophan and turn it into 5-hydroxytryptophan and serotonin? And are there enough cofactors present? But more importantly, are there enough methylated cofactors present? And is the person getting enough iron or absorbing enough iron, or are they losing too much iron from their period to make that happen? Okay, and then do they have a receptor pathology genetically that we need to be aware of? Might they actually be served best by medication, or can we do this nutritionally? That is how we take a deep look at physiology as it relates to chronic digestive disturbance and SIBO. So I'm a little bit over. Thank you for your time, and I look forward to your emails and comments. We've really been enjoying these Facebook Live events. If you have something you'd like us to cover, let us know. The next session we're going to do on GABA. And when we start talking about GABA, we're talking about how benzodiazepines impact anxiety and fear in the amygdala. And we're going to get into the neurochemistry of energy production and where GABA and glutamate come from and that whole story as it relates to the amygdala. We've only covered one of these arrows so far. And in this course, I'd like to cover as many as possible. So thank you for your time.